deciding about terminating a pregnancy is such a complicated, emotional, difficult process. But there are times, say, if a woman has a pregnancy and we do an ultrasound, and clearly that baby is not going to survive. If she carries it to term, it's going to be born and die. We would terminate that pregnancy. There's so many different situations that we had to deal with.
Hey, this is Chad Namiro.
And I'm Kelley Namiro. Welcome to the Balancing Chaos podcast,
a lifestyle podcast where we will interview guests about wellness, business, and just about everything in between.
Our goal is to help you develop a lifestyle that promotes health, wholeness, and success. Through our conversations, we hope to inspire you to live a beautiful, full, and joyful life as you navigate balancing the chaos.
We hope you enjoy. All right, everyone. We have an exciting guest on the show today. It is none other than my mother. So I'm going to have to call her Debbie throughout the episode, which might be strange, but I'll probably refer to her as Mom and Debbie. She is an MD. She's a gynecologist and a gynecologic surgeon who practices out of Scottsdale, Arizona. Obstetrics was her first love, and she delivered over 5,000 babies in 17 years. Due to a burgeoning gynecologic surgery practice, she stopped delivering babies and moved into specializing advanced laparoscopic surgery. She has performed over 10,000 laparoscopic hysterectomies and presented at international conferences on laparoscopic surgery. Always an animal lover and a vegan, she writes and lectures on vegetarianism and health lifestyle. She also has her own nonprofit, which she funds a 30-acre ranch and sanctuary in Prescott, Arizona. The ranch is home to horses, goats, cows, chickens, geese, and donkeys. The property also functions as a dog and cat sanctuary for older animals who have no chance of adoption. She has 4 kids, myself being one of them, of course. And for those of you who aren't aware, she is grandma to West and Enzo. With that being said, welcome to the show, Mom.
Thank you. Thank you, Chad. Thank you, Kelley.
Thank you for being with us. We're super excited to talk to you today. I cannot wait to hear more. I mean, I know Chad knows a lot about how you got into gynecology, and I have heard Jay's whole story before about, how he got interested in fertility. But for you, how did you get into that field? What made you interested in it when you were kind of going through medical school and your residency and all that? Can you tell us more about that?
Well, initially, I actually wanted to be a veterinarian, and that was my.
That makes sense.
Yeah, of course, yes, that was my intention, even into the first or second year of college. But I did work in a veterinary hospital, and back then, this was many, many years ago, people didn't regard their pets the same way they do today. So in other words, I remember somebody brought in a dog who had a broken leg because it had been hit by a car, and they just wanted to euthanize. They didn't even consider having the leg fixed. And it was a very callous approach to their pets. So that was discouraging. And then my aunt, who is since deceased, but my aunt had a conversation with me, I remember, on the porch of our house. And she said, I really think you'd be better off being a human physician and just helping animals in other ways. And so I switched to pre-med. Now, when I was 12, I had been a volunteer, kind of like a candy striper at a hospital in Santa Barbara. Mm-hmm. And I enjoyed the OB ward. I enjoyed delivering babies. I didn't deliver the babies myself, obviously, but I enjoyed watching it and taking care of the babies and moms. So even from early in medical school, I thought that I would probably go into OBGYN, which I did.
So going into OB and being a gynecologist, was that do you feel like that was really challenging work getting through that part in medical school? And is there any advice that you have for anyone who is part of our listenership who wants to be a doctor?
Well, medical school's tough. I mean, it's completely involving. I mean, you really can't do much else in your life while you're in medical school. It's not to say it's bad, because I had 150 students who I became very close to, and it was a real bonding experience. And we'd go out to dinner together, and we'd study together, and we'd play baseball together, and things like that. So it's not a bad experience, but it's all encompassing. There's not much else that goes on in your life during that period of time, and it's a lot of memorization. It's hard, I would sit in class all day long for 8 hours, and then the next day there would be a test on what was presented in that class during the 8 hours. So it was bang, bang, bang. It
Grueling.
was, yeah.
When you're reading about all these diseases and ailments and illnesses, did you convince yourself that you might have one?
Oh, yeah, a few times. Probably not as many as some of the other students, but
That's
yeah,
what I
I
would
ended up
do.
in the ER.
I was just gonna say that's what you had to do.
I'd be like, I definitely have this. I feel tired.
Yeah, I was convinced I had meningitis once, and
Right.
I was convinced I had a stroke. Oh yeah, yeah. It's well, you read about the symptoms, and then you start looking at yourself.
Exactly.
Yeah.
So do you, for anyone who wants to become a doctor, is there anything that you would tell them, like, if you want to do this, like it takes a lot of hours or work or effort? Like, I think that a lot of people think that like everything is easy these days. So is there any advice you would have for anyone who wants to become a doctor?
Well, you just have to be, you have to be really, really serious about it.
Yeah.
You have to be very, very committed to getting that MD at the end of the 4 years or 5 years of undergraduate school and 4 years of medical school, and then another, 3 to 7 years of residency. It's a huge commitment. You really have to want it.
Yeah.
And back in the day, I think it's still 80 hours per week residency these days, but I think in your day it was, correct me if I'm wrong, closer to 100.
There was no limit on it. There was no limit. When I was in residency at St. Joe's here in Phoenix, we had the residency director, who was a wonderful, wonderful man, and somebody I respect. Well, he's passed now, but anyway, I respected him highly. We had a clinic, and so we had our own patients in the clinic, and he said, look, you have your own patients in the clinic and they're pregnant. And so it doesn't matter if you've been on call the night before, you're sticking around for that delivery if she goes into labor. So there are times when I would be in the hospital for 3 days without making it home.
Is that when you had kids? Is that when you had kids?
Yes.
Oh my God.
Yes. But I had nannies. I mean, not with Chad, by the time I had Chad, I was in practice.
Yeah. So for those of you who don't know, Chad has 3 brothers and sisters, so 4 kids, and she did all of that while also managing being an OBGYN and starting her own practice.
Sounds tiring.
Yeah, Chad and I are exhausted with 2 kids and we work from home, so I can't even imagine what that was like.
It's a little crazy, but what's life about? It's okay.
Can you tell us about how you started your own practice, like what led to that decision, and kind of how you got out of, residency and into that?
Well, back then, really, most doctors who wanted to have a practice started their own practice. These days, things are very, very different. It's very difficult to afford to start your own practice and buy all the equipment that you need and hire all the people you need, unless you have a huge loan, and banks are not so amenable to providing those loans. Back then, the banks were begging me to, take their loan, take their money. Mm-hmm. So that's pretty much what everybody did. And there weren't a lot of female gynecologists or OBGYNs back then. So as soon as I hung out my shingle, I was pretty busy. I was very busy within 6 months or so. Yeah.
I think that a lot, like you said, like a lot of women feel a lot more comfortable with a female gynecologist. So I can imagine that you were pretty busy because of that. Like, I know for me, from the time that I had to start going, which is when I was like 16, all the way until I got pregnant with West, my gynecologist was a woman because I was not comfortable going to a man. And then we saw an OB when I was getting ready to have West, who was a male, because he was highly, highly regarded and highly recommended. But before that, I was not comfortable enough seeing a male. So I think that makes a ton of sense that you would have so many patients. How many patients do you have now?
It's hard to say. I haven't looked at the numbers, but it's in the many, many multiple thousands, probably 20, 25, 30,000 if you add them all up.
Over the years.
Yeah, I saw 35 patients today.
Wow.
So that's pretty typical. I've seen up to 50 patients in a day. There's a huge demand right now because many OBGYNs in this area at least retired over COVID.
Oh.
I think I think I saw statistics that said 1 in 5 physicians in the United States has retired over the last 2 or 3 years.
That's crazy.
So we're getting a lot of patients who were seeing other doctors, but they don't have anybody to go to right now.
What's the most common thing that you're doing in your office, like procedure wise? Is it pap smears? Is it mammograms? Is it like surgeries? I know you do like a lot of the, more like med spa beauty type of things. And we're going to get into that because I want to talk about how you've transitioned some of your business there. But like when it comes to gynecology, what's the most common thing you're seeing patients for?
Well, at this point, I actually stopped operating after, many, many years of teaching laparoscopic surgery nationally and, having gynecologists fly in and watch us operate. So I stopped operating in May, right before I turned 70, which is pretty much the recommendation, I mean, you don't want them to call you into the office and say, hey, you're losing it. Maybe you want to consider quitting. You want to make your own decision before that possibly happens. Not that I had any problems. I didn't have any complications at all. But so at this point, I see mostly menopausal women. So what is the most common problem I see? Menopausal symptoms: hot flushes, night sweats, insomnia, depression, memory loss, vaginal dryness, pain with intercourse. I mean, today I was telling Chad earlier, I saw this cute little 74-year-old who's actually a pretty old 74-year-old. And she came in and she said, my husband is a little bit younger and he still wants to have sex and it's just not working because without estrogen, which, at 50 or so, women's estrogen supply ends because we stop making estrogen and testosterone and progesterone and all those hormones. So without estrogen, a 74-year-old woman is not going to be able to have comfortable intercourse because estrogen increases the elasticity and the moisture in the vagina. And without elasticity, you can use all the lubricant in the world, but it's not stretchy. So it hurts.
I think that that's a really interesting topic because a lot of the listeners here, I know, because a lot of my clients are 50 plus, people who have gone through menopause. And I feel like they feel like a forgotten group, like they feel like their needs don't matter. And a lot of times if they have gone to see a male doctor in the past, because I've been told that because of their clients who I've seen, they're like, well, I'm just told, you're getting older and this is what you have to deal with. And as you said, estrogen is really like the water loving hormone. And so it provides that lubrication. Is your recommendation to people like the 74-year-old who you saw today to go on bioidentical hormone replacement therapy? Like what's the solution to that problem in your eyes?
Well, it depends on I always ask them what their goal is. And if they want to have a sex drive and arousal and orgasmic capacity and all of that, then we have to consider systemic hormones, and we don't use anything but bioidentical hormones. So if they want all of that, the little zing and the sex drive, then we have to use systemic hormones. She didn't really care about that. So we can treat this vaginal atrophy and lack of elasticity with vaginal estrogen. And also we have a technology called Mona Lisa Touch Vaginal Laser, which is tiny little laser beams that penetrate the vaginal tissue and kind of tricks the body into bringing in more elastin and collagen in a reparative process. So if we combine the vaginal estrogen along with the Mona Lisa touch, which has been around for quite a few years and tried and true, then we can at least get her back to the point where she's comfortable with intercourse with her partner. Because many times, I mean, who looks forward to something that hurts? Nobody.
Yeah. So is there a
awful for both parties, to be honest.
Yeah,
I'm sorry,
right.
I'm not letting your son get a word in edgewise right now, but I'm like very fascinated by this topic. So, if there is someone who wants so she's comfortable, right? But if there is someone who wants the arousal, is that possible at 74 years old?
Yes.
It is. Okay. And so what do you do for that?
Well, there are just a whole variety of hormone replacement options. The pellets are probably the most popular if you really want to get a sex drive back. Pellets are estrogen and testosterone time-release pellets that we put under the skin. And they release, it's a time-release technology. So they release over a period of 3, 4, 5 months. And really put a woman back into, say, a 40-year-old hormonal balance. So she's going to, as long as she has a good relationship. Now, that's a component of it that I have no control over.
Right.
But if they have a good relationship and they did have a good sexual relationship before, I can usually bring it back with the estrogen and testosterone pellets.
I think that is fascinating. And I think that a question I get asked a lot, and I want to ask you because you're the expert here, is, are there any downsides to bioidentical hormone replacement therapy? Like when we saw hormone replacement therapy in the past, it was a lot of like potentials of cancer and things like that because of the excess estrogens that could, happen. But for you, like if you're using bioidentical hormones and you're balancing them in the right way, is there any downside to it?
No, to be honest with you, the notion that estrogen causes, say, for instance, breast cancer is a myth. It's a pervasive myth, but it is a myth because if one goes through every single study looking at women who are on estrogen or off estrogen who has a higher risk of breast cancer, you're not going to see a difference. And actually, there are some studies that indicate that estrogen decreases the risk of breast cancer. Now, if you have breast cancer and it is estrogen receptor positive, then obviously it's not safe to take estrogen. Although we're able to give these women vaginal estrogen because vaginal estrogen basically stays in the vagina.
Locally.
So it is a myth, and unfortunately it's caused a lot of damage and suffering among women and couples because when the Women's Health Initiative study came out in I think it was 2001, it was a long time ago, indicating that possibly estrogen did increase the risk of breast cancer. Many women went off their hormones, which ended their sex life and caused hot flushes and night sweats and insomnia. And every single brain cell has an estrogen receptor. So without estrogen around, women are going to have memory issues. If you give women an IQ test when they're not on estrogen, and then you give another IQ test after adding estrogen for 6 months or so, they're going to do a lot better. There's no doubt about it. The brain functions better with estrogen. So, so I'm pretty free at prescribing estrogen and testosterone as well, because testosterone is a hormone that the ovaries make, and it is important to sex drive. It's important to mood. I mean, if you give birds testosterone, they sing more.
It's a confidence thing, right? You can have more confidence when your testosterone is right.
Yes, they do. Yeah. And of course, better muscle building ability and better, and obviously a much better sex drive. Yeah.
Is there any way so we had Gary on the show, Brecca, who's a human biologist, a few weeks ago, and he was talking about using supplementation to promote the natural production of testosterone. And he was referring, I think, mostly to males, but
like using DHEA almost like as a precursor to, Yeah.
instead of, so I guess the question is, are there instances where you're choosing that route as opposed to testosterone therapy? Is it mostly the latter?
I usually just go for the testosterone therapy, but I see a lot of naturopaths using the DHEA. It is converted to testosterone to some degree, but usually not enough to accomplish what the patients are coming to see me for. It's not going to rev up the sex drive, and that's a lot of what I deal with. So in answer to your question about what I see most is women who are suffering with the ravages of menopause. I mean, if you look at the history of human beings, in 1900, the average age of death was 50. Average human age of death was 50 in the United States, at least, and probably lower in other countries. So we were meant, our DNA was kind of scheduled to die around the time of menopause.
Yeah.
So we're living far beyond really the way the age we're supposed to be living. Yeah. And so we have to compensate for that. I mean, we compensate, the thyroid gland often gives out around that time or even earlier than that. So we compensate with thyroid. And if the ovaries give out, in order to feel a sex drive and feel the energy level that women want to experience and sleeping well and all that and the clear thinking, we have to supplement.
So one last thing on this topic before we move on, because I want to ask you some questions about birth control. I'm sure your son has some questions as well. What is there any difference between why you would choose, or can you explain why you would choose bioidentical hormone therapy rather than synthetic hormones?
Well, I mean, there aren't even a lot of synthetic hormones out there. I mean, the Premarin is pregnant mare's urine, for heaven's sakes.
Yeah.
I mean,
I got put on that. I got put on that when I was like, I don't know.
What?
Like in my early 20s when I had amenorrhea. Yeah, I got put on that.
Yeah.
It's insane.
I mean, not only is it from pregnant mare's urine, but it's cruel because they tie these poor pregnant horses up and, they tie them up with a 1-foot rope, but they can't lay down, they can't turn around, they can't roll, they can't do anything that horses like to do. So it's extremely cruel for 6 months out of the 11-month pregnancy. That's crazy. No, I wouldn't. No, I'm unwilling to use Premarin. But, honestly, there aren't a lot of non-bioidentical estrogen supplements available. Patches are bioidentical, pills are bioidentical, creams are bioidentical, all of that's bioidentical.
Do you put them on progesterone when you're putting them on estrogen too to balance it?
Yes. Oftentimes, yes, particularly if they have a uterus, because if you overstimulate the uterine lining with estrogen, then you're going to get hyperplasia and abnormal bleeding and potentially even uterine cancer. So we have to use progesterone to balance it. I mean, some women feel great on progesterone, and frankly, some women hate it. So it's, because it does tend to make you tired and hungry. But we have to use it if they have uterus. And we use bioidentical progesterone. We do not use synthetic progesterone.
Hey fam, if you are listening here, then you may be someone who deals with chronic overwhelm, bloating, anxiety, and weight you can't lose, maybe hair loss or skin conditions. If one of those things rings true for you, the Wellness by Kelley Health and Hormones course is available to help you get to the root cause and solve the issue in a way that's sustainable and gives you your lifestyle with lasting results. No more diets or quick fixes, but real health and vitality for the long run. My course runs through everything from what labs to test for to what protocols to implement given what's off in your blood work. We cover a variety of hormonal imbalances and how to heal them, plus the mindset work that you'll have to do to change your habits. If you're ready for an environment where you can learn the tools and truly heal to feel your best, most aligned, light, confident version of you, then this course is for you. If you're feeling called to join the WBK Health and Hormones course, head to the link in the show notes to learn more, where you'll get my membership included with your purchase.
So I think we'll get to a few other topics around female health in a minute, but there was a massive law last week in Arizona around abortion. There's obviously a lot going on around abortion lately, which effectively brought back an over 100-year-old, some would say, draconian set of laws. Tell us about that more specifically, how the medical field is responding, and how you're kind of navigating this in pretty uncharted territories, to be honest.
Well, remember that I don't do obstetrics anymore. So I'm my
Yeah, but you're, associated with it. You're around it. So,
yeah. I mean, the impact on me is minimal, but deciding about terminating a pregnancy is such a complicated, emotional, difficult process. And I can tell you that I never actually in my practice did elective abortions. I didn't do elective abortions. There weren't, there were some doctors in town who did that kind of thing. So if someone wanted to abort a pregnancy that was unexpected and unwanted, we would refer them. But there are times, say, if a woman has a pregnancy and we do an ultrasound and clearly that baby is not going to survive. Say it's an anencephalic, in other words, most of the brain is missing, or it has a genetic abnormality that was discovered on amniocentesis, and that baby's not going to survive. In other words, if she carries it to term, it's going to be born and die. We would terminate that pregnancy. So there's so many different, there's so many different situations that we had to deal with. Or, if a pregnancy is in the fallopian tube, that's called an ectopic pregnancy. And sometimes those pregnancies have a heartbeat, but if that ruptures, the woman could die because she could bleed out. Sometimes women come into the office with a pregnancy, but their body's trying to miscarriage and they're bleeding, they're hemorrhaging, they're bleeding heavily. So all those are fine points that these legislators have no grasp of, no idea about. So that's what is so disturbing about this law that just was enacted in Arizona that says basically there will be no abortions at all, except
so and no exclusions, right? For rape, for incest.
Not for rape and not for incest. To save the life of a mother. Well, who's to say? Who's to say how at risk the mother is if she's hemorrhaging or if she has an ectopic pregnancy? So it leaves us completely blind as far as what to do. And if you're a physician and you cause a miscarriage, you have a jail sentence of 2 to 5 years.
So there's just no real clarity on the legality of this all. So it sounds like people are just scared and obviously angry, I'm sure, but also confused. Is that fair?
Yes, absolutely. The American College of OBGYN is outraged at this because, again, we go to school for a long time and we are trained in residency for a very long time. And these decisions are difficult, but these kinds of decisions require lots of training and lots of experience, not some dude who's sitting in a courthouse somewhere deciding whether a pregnancy should be terminated. And it's absolutely cruel to ask women to carry a baby to term and watch it die if you know that it's incompatible with life. That is the ultimate in cruelty. And I cannot imagine having to make that decision. I had to abort some babies who were, older, not under 12 weeks, over 12 weeks. It's a grisly experience, but I would rather have put myself through a grisly experience than put this woman through an entire pregnancy and delivering a baby who then died. That's crazy.
Horrible. It's horrible to think that there are going to be so many women out there without an option. And I know
well, sadly, I think it's going to affect mostly the lower class.
Yeah.
Because what's the recommendation right now that you're hearing?
Yeah, I think that was my question. It's like I know, 3 of my clients are in Arizona. I know that some of our listenership absolutely lives in Arizona. So what's the recommendation to women who live in your state for what to do if they have an unwanted pregnancy?
They have to go to another state. Many of them are going to Mexico. I mean, how ridiculous is
God.
that? Mexico, it's a Catholic country, but that you can get an abortion over the border in Mexico, or they can go
Wow.
to California, they can go to Colorado, they can go to New Mexico.
Yeah.
Unfortunately, that is the only option at this point, but sometimes there's no time for that option. There's no
Yeah.
time. If somebody walks into my office tomorrow with an ectopic pregnancy in the tube, we cannot put her on a plane or in a car, because it's a life-threatening situation.
Yeah.
She ruptures that ectopic, she can bleed out and die literally within an hour. So for women who have an early pregnancy and they didn't want it, I think there are, particularly in California, there are quite a few options, and there are agencies that will actually help them pay to get there and have an abortion. But you know, that's really the only option at this point, which is very, very sad. And again, I'm not directly confronted with it, but I know that some of the physicians I work with are just horrified.
Yeah, it's horrible. While we're still on this topic of kind of women's health, before we move into talking more about your career and your philanthropy, I know that with a lot of my clients, and even with myself for a long time, I had this major misconception that if I was being put on birth control, then I was getting a period. And that is not the case. You're not getting a real period unless you are actually ovulating. So I'm wondering, why do you think, as a physician, there is so much misinformation around birth control, and that it's going to, quote unquote, fix our period problems? Because it's really not. It's just putting a Band-Aid on it.
That's true. I mean, women are highly motivated to prevent pregnancies. So that's the major reason women are put on birth control. Now most birth control pills, and we're talking about pills, and there are rings and patches and other options, are synthetic.
Right.
It's not my favorite, but frankly, if a woman doesn't want to get pregnant, that is one of the easiest options. But no, you're right. It's not a real period. It's just a bleed off. That's all. It's just a bleed off. So you're stimulating the uterine lining with estrogen. There's a buildup of the uterine lining. Then you come in with progesterone, you withdraw the progesterone, and there's a bleed off. So no, it's not a real period, but birth control pills can reduce the amount of bleeding that women do if they're having really heavy bleeding. I mean, I would never use birth control pills on, say, a postmenopausal woman who was bleeding. We have lots of other options.
Right.
So it's an unfortunate situation, but that is really the easiest way to prevent pregnancies.
Sure. And with pregnancy prevention, if that's a choice that a woman makes, and that's their choice, right? That's the route that they want to go. But when it comes to something like, let's say, PCOS, I've had a number of people come to me and tell me their doctor says, "Oh, you have PCOS, go on the birth control. You're going to get a period." What are your thoughts on that?
PCOS is complicated. It's really complicated. I mean, generally speaking, if we can, these women tend to be overweight, and if we can encourage them to lose weight and clean up their diet and exercise, oftentimes that's going to correct PCOS. And
I'm so glad that you said that, because you're honestly the first physician, Debbie, that I've heard say that. Most doctors will say, go on birth control, but it's an insulin resistance problem.
Yes.
When lots of the time, I would say the majority of the time, when you correct that, you correct the PCOS.
Yeah, it's metabolic syndrome. Yeah. But again, we're dealing with a population of overweight people, and it's very difficult. I mean, you're in a unique situation where women are coming to you, and obviously in coming to you, they're interested in cleaning up their health and losing weight. Yeah. That is not the case in my practice. No,
I hear you.
I would say at least 50% of the patients I see on a daily basis are overweight to some degree or another, and their diets are terrible, and their habits are terrible, and they're not exercising. And so it's a difficult problem from my point of view, because I'm seeing a general population.
And you don't have a ton of time with them. So it's not like you can sit there and, go over all of these things like, okay, here's what you need to eat, and here's how often you have to exercise. It's like, that's something that they have to look into on their own and be interested in actually healing their health. But I'm really glad that we got to connect those dots in this podcast, because I think that for so many people, the idea that menstrual health could be connected to, you know, being overweight or being obese. And I'm not saying that in a way that is, you know, pointing a finger or being, you know, accusatory, but it really is, there is a direct correlation with those two things in terms of, you know, what you're putting in your mouth and how your body is responding with your period. So
yeah, you're right. And thank you for pointing out that I don't have a lot of time with them. I mean, you know, seeing 35, 40, 45 patients a day, I've got to take care of the immediate problem and move on, or else, you know, people don't like waiting for hours to see a doctor. They don't like it. So we get complaints. Yeah.
So will you tell us, just before we get off this topic, if you are a cycling woman and you're not on the birth control pill, you're not on an IUD, a hormonal IUD, you're not on the patch, how far apart normally should your menstrual cycles be? What is considered normal?
Normal would have to fall in between 21 days apart and 32 days. I think that's what the American College of OBGYN says. So between 21 and 31 and 32 days apart. And a normal bleed should be about 5 days. But you know, when you look at overweight women, peripheral fat converts other hormones like adrenal hormones into estrogen. So these overweight women are bathing their uteri in estrogen. So they'll tend to have heavier periods just because they have more estrogen around. I mean, the same thing goes for menopausal women. Menopausal overweight women don't have as many menopausal symptoms as, say, a non-overweight woman, because she's still got estrogen around from her peripheral fat. So it's interesting. So I have plenty of overweight women who are just, you know, not phased about menopause at all. I'm fine. Yeah.
Wow.
That's fascinating. Thank you for sharing all of that. That's really great information for our listeners.
So bear with the male here, but I have a question for you. Do you think that years, if not decades, of younger women being on birth control in any form, in any way, permanently affects their fertility systems? And the basis of my question is infertility is perceivably on the rise, and there's, I think, a lot of factors: stress, diet, chemicals in our daily lives, etc. But to me, not knowing, you know, the biology of all this, I look at it as, you know, a lot of women spend 10 or so years, whatever it may be, telling their fertility systems to not be productive, to be turned off, essentially. And then in many cases, they get married, they get off the pill, and they want to be pregnant, you know, very shortly after. And some women really struggle. So do you think there's a permanent effect there? And are you aware of any studies that have researched this?
It's an interesting question. I haven't seen a study that looks at that directly. I haven't seen a study that looks at that. I mean, I have seen, you know, that's not the major focus of my practice anymore. So frankly, I don't pay a whole lot of attention to that kind of literature. But there have been studies in the past that show that actually being on birth control pills suppress ovarian cysts, and so they reduce the number of surgical procedures women have, and so in some ways it can enhance fertility. But I haven't seen any solid evidence about that. I mean, I think infertility, the rise in infertility, and there definitely is a rise in infertility, has to do with many women waiting longer to get pregnant. Eggs get old, and then the longer you wait, the more chance you have of developing ovarian cysts that need to be operated on, or endometriosis. You know, endometriosis is a huge component of infertility. And the longer you wait to get pregnant, the more endometriosis you give your body a chance to develop. So it's a tough one, but the honest answer is I haven't seen an actual study that addresses that question. It's an interesting question.
Yeah, I think that your dad kind of said the same thing. It's like it's really an age thing, and then from there, it's like, there's so many factors, multi-layered factors, but it is an interesting question as to why more women these days are dealing with it than ever before.
I've heard it both ways.
Yeah.
I have a friend who was on birth control, I think, for 10 years, and she got pregnant a few months later.
Yeah.
So
you never know.
interesting.
So tell us a little bit. Okay. So I want to talk about like finding, because you did do OB for a really long time. Like we said, you delivered 5,000 probably plus babies.
We're dusting off the history books.
I'm going to tell a story here that and I'm not going to name the doctor because I would never do that. But when Chad and I got pregnant with West, we went to see a doctor here in town who, like I said, will remain nameless. But when we first went to see him, I was like, I have a birth plan and like, this is my first baby. I was so excited. Like, this is what I want. I want a vaginal delivery. Like if I can keep the baby safe, et cetera, et cetera, et cetera. And basically his response to me was like, no, we're going to do this my way. You're going to get induced. We might end up doing a C-section, like, et cetera, et cetera. And that for me, I was like, see ya, I'm going to find somebody else. And I ended up finding the doctor who we've used for both of our boys, Paul Wilkes. But can you tell us, like, if someone is looking for an OB, are there certain qualities that they should be looking for when they are looking for someone?
Yeah, I mean, I can tell you a story from my own experience.
Yeah.
When I was pregnant with Chad's older sister, Aria,
Mm-hmm.
she was born in 1979. We were back in Washington, D.C. I had just completed, I was still in medical school as I was pregnant. And I went to a similar doctor who told me, this is the way it's going to be. You're going to go back to the operating room. You can't have a baby anywhere but in the operating room. And you're going to have an IV and you're going to have this and that. And I ended up having a home delivery. I was not going to buy into that.
Yeah.
So we delivered at home with a midwife.
Good for you.
And some doctors are very open to the birth plans. I mean, you could tell right away that this guy was not going to go along with it. I think it's very important for doctors to respect the desires of the pregnant woman. Yeah. Sometimes it doesn't turn out that way.
Because you're trying to keep someone safe or someone healthy, but there is a respect factor at play. You're so right.
Mm-hmm. Yeah. So, I mean, you can tell the first time you meet with a doctor whether they're open to, to no epidural and delivering in a bathtub or whatever, whatever the woman wants to do. Mm-hmm. So, and I think things have changed quite a bit over the years. We have birthing centers now and nice music and tubs for some women and that sort of thing. So things have changed, but I mean, I was always very much open to whatever they wanted to do.
Yeah.
And that's probably why I ended up delivering 5,000 babies.
Yeah.
So but if your doctor says something like what you just recounted, then no, then
time
it's
to move on.
No. Yeah. I mean, and I saw there was a question about C-sections. Clearly, the rise in the C-section rate has to do with medical legal risk. People, doctors don't get sued, generally speaking, for doing a C-section. They get sued for not doing a C-section.
Yeah.
And also, I'm sure there's a element of convenience in it. I mean, I always had a pretty low C-section rate, but I spent the night in the hospital many, many times.
Yeah.
So, but we were monitored. Our C-section rates were monitored back then. And if our C-section rate was over 20%, we got talked to. I don't think
so. Is that not the case anymore? Because I feel like 1 in 3 births is a C-section. Is that a stat? Is that right? I don't know.
I don't know because when you stop doing OB, it's like you get your journal.
You get lost.
You go right past the OB articles. So, but that wouldn't surprise me at all. But the medical legal situation out there, particularly in the area of OB, is really pretty treacherous. I mean, you get a bad baby for whatever reason, and there are lots of reasons that have nothing to do with what the doctor did or didn't do, and you know, you're going to settle that case. So it's a tough situation.
It's unfortunate. I read a lot about it when we were getting ready for West, etc. And they 100% are on the rise. 1 in 3 sounds about accurate from what I remember. And it's a pretty unfortunate circumstance, because I think there is a ton of malpractice lawsuits versus in the past. And a lot of doctors love what they do and they want to stay employed. And so this is de-risking it for them. And that's unfortunate that that's the paradigm it operates on, but it is the reality. So.
Yeah. And a C-section is not the end of the world. I mean, honestly, putting a huge baby through a small pelvis and getting a 4th degree tear into the rectum and violating the fascial tube that goes around the vagina and the hammock of fascia that exists in the base of the pelvis. I mean, it's relegating you to have surgery later, that's for sure. You can bet on it. So, you know, if the choice between doing a C-section and just going to the end of the earth to get a huge baby out of there, you know, I'm not so sure that's a great idea, because you are relegating her to surgery later.
Yeah, it's a wonderful option that has saved many, many lives, I'm sure. So of course
it is, but it's obviously overused.
Right.
So a couple of quick fire questions that are will be really easy for you to answer before we talk about your career. First of all, I think there's a lot of confusion out there. How often should a woman be getting a pap smear?
Oh boy. Yes, there's a lot of confusion out there. You know, there's so many different recommendations. Here's the thing. A pap smear is a very, very easy test. And it's not like a colonoscopy, you know, it's not like a endoscopy. It's not a big deal. So personally, we still recommend yearly pap smears. Now, you know, you're going to see many recommendations that say, well, a woman doesn't even need a pap smear until she's 25 years old. And after 65, who needs a pap smear? Because, you know, who cares? So I personally still believe that a yearly pap smear is not a bad idea, because, you know, and I see that in my practice. I just did a pap smear on a woman the other day who hadn't had a pap smear in quite a while because her doctors were telling her she didn't need it. And sure enough, she had high-grade dysplasia, which if it wasn't addressed, it would have progressed to cancer. That's mostly what high-grade dysplasia does. So I still think a yearly pap smear, you know, allows the doctor to talk to you about how you're feeling. It allows us to look at the vulva. You know, there are squamous cell carcinomas and melanomas that occur on the vulva, and oftentimes they're asymptomatic. I just had one in the other day. I took a look and said, "Are you aware of this area down here?" No. Well, it was, you know, squamous cell carcinoma. So it's just a check-in, and it's such an easy, you know, how long is the GYN exam? 5 minutes. It's I hate to see
go in and get it done, ladies. Go in and get it done.
Just go in and get it done. Don't put it off. You know,
and how old should you be when you get your first mammogram?
I think 50 is probably a safe number. Some studies indicate that 40 is better, but there have been studies that suggest that a mammogram under 50 doesn't really save any lives. So 50 is reasonable. I mean, you know, radiation is not your friend. And you don't want to have more radiation in your life than you have to have.
Right.
So it's, you know, it's always a balance. Now, these days, mammograms emit very little radiation compared to the way they were 20 years ago, but still, you know, but we do detect a lot of breast cancers on mammograms.
So you've transitioned away from clearly delivering babies many years ago, and then even so, OBGYN as of a couple of years ago, I think, into more like lasers, school sculpt, end sculpt. Can you tell us what drove that decision and your strategy behind the move?
Well, it's, for one thing, it's kind of fun. It's interesting. It's kind of fun. Women appreciate it, and women would often ask me my opinion about some of these things, like M-Sculpt Neo or radiofrequency microneedling, the Morpheus that we do on the face and in the vagina. So there was an interest, and frankly, to be frank with you, it's cash. And taking insurance only, it would be very difficult to have a practice like we have, where your question is answered within an hour. We have enough staff to really serve the patients well.
That's amazing. You pride yourself on answering a question within an hour. If somebody calls with a question, that is incredible. Like, if you live in Arizona, you should go see my mother-in-law, because there is no medical practice in Las Vegas. Like, I called about a question about breastfeeding with my pediatrician a few weeks ago, and they just never called me back. Like, I think that is one of the most amazing things that I've heard you say through this entire podcast. 1 hour to get a question answered. That's awesome.
Yeah, generally speaking, I mean, I'll get a little message at the top of my electronic medical records screen, and I'll answer it right away. And then it gets put on the patient portal.
Yeah.
So in order to provide a quality of care that is important to me, you have to have some cash inflows. If you try to depend completely on insurance, you are not going to be able to do it.
Yeah.
And there are practices that try that, and we get complaints, just like you said, you didn't even get your question answered ever.
No.
And I hear that all the time. Well, that would not happen in this practice unless, once in a while something falls through the cracks, but that's very, very unusual. I mean, we have a full-time triage person sitting right on that phone, looking at that screen, answering questions all the time. And that's the way it should be.
Because people get really worried and concerned about their health, like especially like gynecological health. Like, if something comes back like abnormal or irregular, I've had an irregular pap smear before, and I wanted answers like immediately, like, tell me what's wrong with me. So I think that's great.
So, for example, a pap smear, how much of your time would be spent on that? What would you bill that out to the insurance at? And what would you typically collect back, just to understand like the financial component of what that means in today's world?
Oh man, not much. I mean, maybe $100, $100. And that's not a lot because it's not just my time, it's everybody else's time in scheduling the patient and the MA working the patient up. So yeah, like 100, like if say a Medicare patient comes in, Medicare patients are allowed to see the gynecologist. It gets paid for every other year. And if they want to come in that intervening year, they pay $100. Well, some of these Medicare patients have lists of medications a mile long and lists of surgeries, and it takes a long time to get a hold of their general medical condition. So unless you have a cash inflow. Now, the aesthetics, we do Sculpt Neo, we do microneedling, radiofrequency microneedling of the face. We do peels, we do hair removal, we do tube removal, we do brown spot removal. I mean, we do a whole list of aesthetic offerings, but we also have what we call the intimates. We have radiofrequency microneedling of the vagina, which tightens the vagina after oftentimes women have a number of kids and they end up kind of loose. We have high intensity focused electromagnetic energy. We have 2 different technologies that strengthen the muscles in the base of the pelvis. None of that is covered by insurance, and pellets are not covered by insurance. No insurance company covers them. So this is all cash influx, which allows us to do what we do.
What's the fastest growing procedure out of the ones you just listed, or the most popular?
Well, for the face, it's radiofrequency microneedling. It's more.
I just had that done in our house. Oh, not the radiofrequency, but microneedling. And Chad was looking at me like I was a crazy person.
I never know what she's up to. But I'd heard on a different podcast of vaginal rejuvenation stuff is huge.
Huge. It's absolutely huge. But that's also radiofrequency microneedling or laser. And then high intensity focused electromagnetic energy, which is the Emsella chair, where you just sit on a chair and it strengthens the muscles, or there's a device that goes in the vagina called V-tone. These are InMode makes a platform that offers the radio frequency and the high intensity focused electromagnetic energy. So yes, it's an up and coming a very, very popular technique and technology. Mhm.
So do you see more of your patients coming in for their face or for their vagina?
Well, they don't really come to me for their face. I mean, they'll mention it to me and I send them up to my estheticians. I
Right.
have 2 fabulous estheticians. So they come to me more for their vagina.
But
Yeah.
like, which procedure would you say is more popular in your office? Or is it like pretty 50-50?
Probably more women are having their face done.
Yeah.
Yeah.
Okay.
Yeah. I mean, it's the radio frequency microneedling of the face is, I've had it done a few times and
Yeah.
it really has made a difference in my skin.
Is there a downtime associated with the radio frequency part?
It depends on the person. For me, I'm very reactive and very allergic. And so it wasn't a downtime, but I certainly looked a little bizarre for a few days. But, but then that sells more radio frequency microneedling because they know their doctor's doing it.
Yeah.
I was
Right.
swollen. I was definitely puffy for a few days and had, red marks on my neck.
Okay.
But it goes away.
As we approach the end of the episode here, I just had a question around, like, is there anything you've read, a piece of research or a journal as of late that significantly changed your practice or not your belief strategy, but just your field in general, if any?
Well, yes, there have been a number of articles. For a long time, if a patient had breast cancer, we were not allowed to use any estrogen at all. They were just relegated to, vaginal dryness and pain with intercourse, and there's just really not much we could do. So over the last year and a half or so, the American College of OBGYN has looked at studies and decided that these women can use vaginal estrogen, which has been a huge opening, a real relief to so many women. So yes, there have been 2 or 3 articles that have fortunately changed the way I practice menopausal medicine and given these women an option that they didn't have before.
I think that this episode is going to be so helpful for women who have gone through menopause. Like I said, I would say probably like maybe 40 to 50% of my clients and a lot of the people who follow me on Instagram are in that stage of life. And I think this is going to be really helpful for them. So to kind of wrap things up, you are, like, as we've noted, a very busy woman. You see a ton of patients a day. You are also traveling back and forth, state to state, for personal things. Can you tell us a little bit about how you keep yourself feeling healthy and keep yourself feeling mentally clear and energized? Because what you're doing I'm not saying that you're old, but like at your age is very impressive.
I'm 70. That pretty much qualifies as old. I think it even technically qualifies as elderly. Well, I do yoga every night. That's just the rule. Every night I get yoga online do yoga with me, and I do yoga for at least a half an hour every single night. And that's very important. And
is it more for your body or more for your mind or both?
Both. It's really both. Yeah.
And how do you stay so disciplined with something like that? Because there are so many people out there who will say, well, I'm just going to skip it tonight.
I'm going to pour myself a glass of wine and relax. It's just, if you do something long enough, it really does become a habit. And if I skip it, I just don't feel good the next day.
Yeah.
So it has become an absolute habit.
Yeah.
Sometimes I'm really tired. The nice thing about yoga online is that you can choose the intensity of your practice, and you can choose the length of time the session goes on. Right. So that's pretty much, sometimes I meditate. Lloyd would like to see me meditate a lot more than I do, but meditation is helpful. It's just sometimes in the morning I just want to sleep a little more.
So for those of you who don't know, Lloyd is her boyfriend and he is a meditation expert. And so that would actually he would be a great person to have on the podcast.
Yeah, he throws down like 24-hour cycles. So
so yoga, and then tell us a little bit about your diet, because over the years I tried 1,000,001 different things, and being plant-based is what works for me. And it is very, very, inspired by you and your daughters. You guys have lived that way for a long time. So can you tell us a little bit about that?
Well, I was raised as a vegetarian. When I was growing up, we lived next door to my grandparents, my father's parents, and my grandfather was a vegetarian. He was a follower of George Bernard Shaw, who was a very famous vegetarian. Animals are my friends and I don't eat my friends.
Yeah.
That was his quote, among many other wonderful quotes. So he was vegetarian, and I was the oldest, and my parents kept having kids, and so I spent a lot of time at their house, and I was highly influenced by his ethical vegetarianism. So I've never really had much in the way of meat in my whole life. But then I did, so I was a vegetarian for a long time. For a little while, I ate fish, which I would never do now. We're just decimating the oceans, and it breaks my heart, honestly. But I did a weekend PETA session, probably, I don't know, 20 years ago, and saw what the dairy industry did to cattle, and how inextricably tied to the veal industry it is. So I became vegan. So I haven't had dairy or eggs or any of that stuff for probably 20 years at this point. So and I feel good. I am healthy. My blood work is wonderful. My cholesterol is like 165.
Yeah.
So I think for the planet, it's the best way to go. I don't think there's any doubt about that. And for bodies, I think it's the best way to go. The way we evolved, once in a while, people thousands of years ago would make a kill and they'd eat meat, but it wasn't a daily thing at all.
Yeah.
So, and we don't have teeth. We don't have big old fangs to tear apart meat. If we were meant to eat meat, we'd have bigger fangs. So, no, I think it's important. I think it's very important.
Yeah.
And I feel good at 70. Hey, Lloyd and I just did a 6-mile hike up in the mountains of Colorado on Saturday. I was pretty proud of myself.
Incredible.
So one last question for you, because I know you're big on this, like we just talked about. I think there's a really big misconception out there that if you're plant-based, you don't get protein. So Can you explain to our listeners, what are the best sources of plant-based protein, and how do you make sure you're getting enough protein every day? And what is enough?
Probably 20 grams of protein a day is enough. And we eat, as an American society, we eat way, way too much protein. And the only thing that comes with a whole lot of protein is cancer and heart disease. So we don't need anywhere near the amount of protein that we take in.
That's so crazy. I had someone telling me the other day that she gets 150 grams of protein a day.
That's insane. Yeah, that's insane. Now, if she's just getting it from protein drinks and things like this, that's one thing. But if you're getting it from steaks and chicken and, and ribs and whatever else you're eating, then that's going to come with some real potential problems in your body. But as far as the best sources of protein, beans, garbanzo beans, lentils, things like that. But almost anything, particularly in the bean family, soybeans, they have plenty of protein in them. Plenty of protein. Quinoa has a tremendous amount of protein.
And all 9 essential amino acids.
Yeah, exactly. So there's no problem getting enough protein in a vegan diet. And frankly, I don't even worry about it. I don't think about it.
And like for someone like you guys, it's audio on the podcast, but if you see the video reel of the podcast that we put up this week of Debbie, with like her hair is like the most gorgeous hair I've ever seen. And you can't have gorgeous hair unless you have a healthy inside and enough protein. So clearly she's doing something right.
That's where I get my grays.
Yep. It's hereditary.
Better than the other one.
Better than
Yeah,
losing it.
exactly.
Well, thank you. I think this was great.
This was honestly one of my favorite episodes that we've done. Thank you, Debbie.
Okay, well, you're very welcome to both
love
of you.
you.
I love you both.
Love you too. Thanks for being on the show, Mom.
Okay, you're welcome. Bye-bye.
We really hope that you enjoyed that episode. You can follow me on Instagram at Wellness by Kelley. And if you're new around here, you can sign up for the WBK 7-day free trial where you can get access to all of my low impact workouts, blood sugar balancing, plant-based recipes, and guided meditations, all available on wellnessbykelly.com and on the WBK app.
Hey, thanks for listening.
Please make sure you rate, review, and subscribe to the podcast. You can also connect with us on social media at Wellness by Kelley. Drop us a DM for who you want to hear from.